Hello and welcome to a post-recording of the February ICU Journal Club. We're reviewing the AID ICU trial today. My name is Bob Gibson. I'm an acute care nurse practitioner. I have no relationship with industry, nor do I have any financial disclosures. So let's get into a bit of background on haloperidol before we examine our current paper. So haloperidol is a first-generation antipsychotic, and it's actually the most frequently used agent to treat ICU delirium. What is ICU delirium? More so, what is the pathophysiology behind it? And we don't fully understand it yet. And the way that I think about it, it's a moving target. There's multiple different forms, there's multiple different etiologies, so we don't know exactly what causes it, but we know that neurotransmitters play a massive role. A traditional theory is that delirium is caused by a cholinogenic deficiency with excess dopamine. So now cue haloperidol. What's its mechanism of action? Well, it's predominantly a dopamine receptor antagonist, and it also has a acetylcholine agonist effect to it. In this graphic, what I really want to show you is that all antipsychotics are not created equally. Haloperidol, once again, has a predominant dopamine receptor antagonist effect, while other more advanced next-generation antipsychotics have a multitude of mechanisms in action. There's an immense amount of literature out there concerning haloperidol, but I would like to highlight two papers before we move forward into our journal club. The first one will be the HOPE ICU trial, and this was released in 2013. It asked the clinical question, does early treatment with haloperidol decrease delirium or coma? So this was a UK trial, randomized and blinded. It included adult ICU mechanically ventilated patients, and the intervention was haloperidol, 2.5 milligrams IV every 8 hours. Now, in both groups, they were sedated with propofol and fentanyl, and there was a targeted RASS level of 0 to -1. Haloperidol was given to all comers, so irregardless of whether they had delirium. So this paper was really looking at a preventative role for haloperidol. However, they found no difference in delirium-free days or coma-free days. They also found no difference in mortality, length of stay, or ventilator-free days. Now, there was a post hoc analysis, and it showed that the haloperidol group had less patients with a RASS greater than +1. So essentially, the folks that got haloperidol were less agitated and less hyperactive, which makes sense. In addition, there was a non-statistical trend towards less fentanyl, propofol, and midazolam use in the haloperidol group. The next paper to take a snapshot of would be the MIND USA trial, and this was released in 2018. They asked a different clinical question. Does the administration of haloperidol or ciprasidone improve the number of days alive without delirium or coma? Now, this was a USA-based trial. It was randomized, it was blinded, and it was randomized into a 1-to-1-to-1 fashion. So one group was placebo, the other group was haloperidol, and the last group was ciprasidone. This paper included delirious adult ICU patients that were either in shock and or respiratory failure. And the intervention included either getting haloperidol 2.5 milligrams IVP every 12 hours or ciprasidone 5 milligrams IVP every 12 hours. Now, there was some nuances with dose changes and regimens, but the take home here was that they found no difference in days alive without delirium or coma, and no difference in ventilator days, ICU length of stay, hospital length of stay, or mortality. Now, every paper has its limitations, but the biggest critique of this paper was the delirium motor type. So of the population included in this trial, 89% of the patients had hypoactive delirium. So to clarify, hyperactive delirium is when a patient is agitated. This is what we routinely think about with delirium. They're pulling IVs, they're pulling lines, they're trying to get out of bed. But hypoactive is when a patient is more somnolent, they're withdrawn, they're despondent, they're showing inattention. 89% of the folks in this paper experience hypoactive delirium. The last tidbit of background worth discussing here is the PADIS guidelines. So the PADIS guidelines are the pain, agitation, sedation, delirium, immobility, and sleep disruption guidelines. If you take a spin through the guidelines, you will find a preventative and treatment section for delirium. And as you can see, when it comes to the prevention of delirium, the guidelines suggest not using haloperidol. You can take a look at the delirium treatment section and you can see we suggest not routinely using haloperidol. So I have 2 points here. One, they really give no suggestion for a pharmacological regimen to prevent or treat delirium. And then lastly, take a closer look in that treatment section. It says routinely. We suggest not routinely using haloperidol. So if you read more into the rationale of the guidelines, it then goes on to say, although this recommendation discourages routine use of anticholinergic agents in the treatment of delirium, patients who experience significant distress secondary to symptoms of delirium such as anxiety, fearfulness, hallucinations, or delusions, or who are agitated and may be physically harmful to themselves or others, may benefit from short-term use of haloperidol. So first, my questions to you. Do you use haloperidol for delirium? Do you use haloperidol for hyperactive delirium? If you do use haloperidol for hyperactive delirium, do you expect a reduction in mortality and/or hospital length of stay reduction? And then lastly, but I think most importantly, do you use haloperidol for hypoactive delirium? So obviously we're on a recorded webinar and you can answer me, but let these questions simmer in your mind as we're reviewing this paper together. Without further ado, let's introduce our paper we're going to evaluate today. So this is the AID ICU trial. It was released in New England Journal of Medicine in October 2022. Haloperidol for the treatment of delirium in ICU patients. The clinical question: does the administration of haloperidol in delirious ICU patients reduce the number of days alive and out of the hospital? Let's expand on that clinical question by looking at it in PICO format. The patient in the population are adult ICU patients that are positive for delirium. In order to be positive for delirium, a screening tool such as the CAM-ICU or the ICD-SC screening tool had to be used and be positive. The intervention is haloperidol 2.5 milligrams IV push 3 times a day, and we'll explore that in more detail in just a moment. The comparator is a placebo, and the outcome is the number of days alive and out of the hospital within 90 days after randomization. Let's start taking a look at the design and the methods. So this was a multi-centered trial out of 16 sites in Denmark, Finland, UK, Italy, and Spain. So essentially a European trial, but we are going to discuss this in more detail shortly. It was randomized, it was blinded. I would like you to take note of the enrollment date, June 2018 to April 2022. We all know that COVID occurred within that. I think this is particularly important to point out considering this is a delirium and a sedation trial. The trial protocol was approved by the ethics committee. I feel that's important to point out because we're going to discuss how they obtained consent in just a moment. The trial protocol was published before the trial was started, which is always a strength. So the enrollment of the patients was predominantly allowed to be an emergency procedure. They waited to enroll and screen the patient and obtain consent until the patient was actually delirious. So there was only one way to really obtain consent in the majority of the cases because the patient didn't have capacity, and that was the MD to discern consent to be able to start the trial drug. But once a next of kin or surrogate was available, yet another form of consent had to be delivered. And then once the patient was no longer delirious, then that patient had to give their consent to continue on with the trial. The intervention period was from randomization until death or discharge in the ICU for a maximum up to 90-day follow-up. There was a safety interim analysis. It was pre-planned, again a priori. It was triggered once 500 patients were followed up at 90 days. There was a 1-to-1 randomization to the haloperidol and placebo group. Moving on into the study's inclusion criteria. You had to be adult and admitted to the ICU for an acute condition. Definition of adult was 18 years or older. And I kept seeing in the paper, they kept saying acute condition. This made me take a look at the supplemental, and in fact, it did mean more than just some extra verbiage. So the inclusion criteria did not include any patients that were a planned post-op recovery, and it didn't include any patients that were at a step-down level admission. Other inclusion criteria: the patient had to be positive for a delirium screen. This would be through the CAM-ICU or the ICD-SC. That's the Intensive Care Delirium Screening Checklist. And then lastly, the patient could be enrolled and screened at any time during their ICU stay. There was a multitude of exclusion criteria. Contraindication to haloperidol. This could be sensitivity, allergy, QTC prolongation. Chronic use of antipsychotic medications. This sounds appropriate. Treatment with antipsychotics prior to the inclusion of enrollment. So this could have occurred, the patient could have got a dose in the ICU before they were screened and or enrolled. Dementia or intellectual disability. Coma or language barrier, and this more applied to the inability to be able to perform the delirium screen. Withdrawal of care or brain death, pregnancy, which is standard, delirium tremens, the inability to obtain consent, And lastly, patients under cohesive measures by regulatory authorities. They didn't really clarify what this was. I thought it was a prisoner, but as we look at some of the recruitment data, it looks like these were involuntary hospitalizations, whatever that means. Taking a closer look at enrollment, they started with 1,738 patients. 738 patients were excluded. There was a good chunk, 427 of those patients received antipsychotic agents in the ICU prior to screening enrollment, and that made them excluded from the paper. There was another 110 patients that had consent issues. I'd like to point that out, and we'll build on that in just a moment. So from there, we had 1,000 patients that underwent randomization. This got us down to 510 in the haloperidol group and 490 in the placebo group. We then had another 13 lost to exclusion. 7 had consent withdrawn by the surrogate decision maker. 4 did not meet inclusion criteria, and 2 were discharged from the ICU. This moves us down to 501 in the haloperidol group and 486 in the placebo group. Now there was even more exclusion. They lost another 24 patients, again, due to consent issues. So those 24 patients were not included in the primary outcome analysis, but they were included in the follow-up data at 90 days because essentially that 90-day data gathering was observational data and it was nothing to do with the intervention or change of care. Always important to take a look at the baseline characteristics. There's a lot that could be taken away from this information, this chart here, but overall, pretty equally matched. Some things that popped out to my eyes. Number one is the severity of the patient population. So they used that SMS ICU score to predict mortality. We'll talk about that in just a moment. But this mortality risk is pretty equal between the two groups. The biggest highlight of this chart is the incidence of hypoactive and hyperactive delirium. So as we look at the delirium motor types, the population in this paper, there was 55% patients that had hypoactive delirium, where 45% had hyperactive. So this is a little better than the Mind USA trial, where they had 89% being hypoactive, but still, even in this trial, greater than 50%, greater than half the population were suffering from hypoactive delirium. And lastly, I feel myself just wanting to know more about the patient population. When it comes to coexisting conditions, we really only know if they had cancer or COVID. We know a tad bit more as far as risk factors for delirium. So did they have history of TBI or stroke, mental illness, neurodegenerative disease, or did they drink or smoke? But I really want more information. Lastly, just taking a look at that SMS ICU. So this stands for Simplified Mortality Score in the ICU. So this is a mortality predictor. And quite honestly, there's so many mortality predictors out there I get confused, but the SMS ICU is up and coming. It's internally validated. There's multiple studies that are strengthening its external validation as well. Essentially, it's formed on a 7-item scoring system, 0 to 42 points. Obviously, the higher the points, the higher the mortality risk. And a general rule of thumb, anything over 25 equates to a 50% or greater mortality risk. Moving on to take a look at the interventions in a little more detail. Patients received either haloperidol at 2.5 milligrams IV push 3 times a day, or isotonic saline IV push TID as the placebo. Important to point out these are blinded. As you can see, they're equal volumes. They were blinded with dark brown glass ampules, and they were labeled by the pharmacy at the lead site. We'll call this the trial medication moving on because either they were getting haloperidol or the placebo, but additional doses could be administered for refractory delirium or agitation, and there is a maximum daily dose of 20 milligrams, and that equated to 4 mLs, whether that was haloperidol or the placebo. If there was uncontrollable delirium or agitation, rescue medications could be used. This consisted of propofol, benzodiazepine, or alpha agonist. They weren't in particular in stating it, but I would assume this would be dexmedetomidine. And then patients were only treated with the trial medication if they were delirious. So if their next delirium screen was negative, the trial medication was paused. And if subsequent delirium screens were positive once again, then the trial medication was restarted. Now let's say the patient was transferred out of the ICU, but they bounced back, they were readmitted, and once again found to be delirious. Then once again, the treatment was resumed as long as it was within that 90-day follow-up limit period. Now let's take a closer look at the primary outcome. The number of days alive and out of the hospital within 90 days after randomization. So I want to say that one more time. The number of days alive and out of the hospital within 90 days of randomization. So what we just saw, what we're seeing right now is what we refer to as a composite outcome. And the definition of a composite outcome is a combination of 2 or more outcomes into a singular outcome. So in this case, we're really looking at death and hospitalization. The number of days of life, i.e. death. Out of hospital, i.e. hospital length of stay. So composite outcomes seem to be somewhat of a debated topic in critical care literature, so I thought I would educate myself a bit further and then also share with you. So looking at the pros and cons of composite outcomes. So some folks say composite outcomes might be easier, but nothing in statistics is easy. What I think they mean is that they can gain their statistical relevance quicker. And with that, it's because there's higher event rates. And if there's higher event rates, your sample size can be reduced in your power analysis. So this should equate to less enrollment length. So the length of the trial should be shortened. And hopefully that relates to a reduction in cost. Now there's cons of everything as well. So composite outcomes could be misleading. They're difficult to interpret. And if you don't interpret them correctly, obviously you might under or overestimate the power or the effect, I should say. So again, we have a composite outcome, the number of days alive and out of the hospital within 90 days after randomization. So our singular outcomes within that composite are death and hospital length of stay. So singular outcomes within that composite outcome must have similar clinical importance. So is hospital length of stay as important as death? I'll let you answer this. Next, the frequency and effect of the components need to be similar. So frequency, how often they occur, and the effect. To me, in my mind, that's the severity to the patient. Is hospital length of stay the same effect of death? Again, I'll let you answer this. And then it should be clinically relevant and a valid measure to clinical benefit of the treatment. So in this case, death and hospital length of stay might be good and applicable. And then lastly, if suitable, a single primary endpoint, if it's available, then the composite outcome shouldn't be used. So we'll talk more about this when we get towards the end of this review. Looking at secondary outcomes, we have the number of days alive without delirium or coma. We have the number of days alive without mechanical ventilation at 90 days. We have the number of patients with one or more serious adverse reactions to haloperidol in the ICU. We have the number of patients receiving rescue medications, and the ones that receive those medications, essentially how long did they need them for. So to sum it up, the secondary outcomes was looking for delirium, coma, vent days, adverse effects, and rescue medications. Looking briefly, superficially at the statistics, based on a previous cohort study, they made the assumption that haloperidol would reduce the incidence of death and a shorter hospitalization by about 15%. And if they combine that, their composite effect was around 8%. So their power analysis was for 1,000 patients. They assigned 90% power. So that means there's a 90% chance there will not be a type 2 error. They assigned an alpha of 0.05 or 5%. This is quite common medical literature. And to me, what that means, it's the probability of the results being wrong. So there's a 5% probability of the results being wrong. The statistical definition of that is the probability of rejecting the null hypothesis when the null hypothesis is true. Now let's take a look at results. So our primary outcome, the mean number of days alive and out of the hospital, there was no difference. So 35.8% in the haloperidol group and 32.9% in the placebo. Now let's take a look at the secondary outcomes. So secondary outcomes are hypothesis generating. There was no difference in days alive without delirium or coma. There was no difference in days alive without mechanical ventilation. There was just a tiny uptick in serious adverse reactions. They found an adjusted relative risk of 1.2 in the haloperidol group. There was just about the same amount use of rescue medications with the adjusted risk ratio of 0.93, and there was no difference in the days with rescue medications that were needed. So zooming up on this primary outcome here, we can see that they took the primary outcome, which was composite, and they split it apart to take a look at it in more detail. So they found the death, the overall mortality, actually had an adjusted relative risk reduction of 0.84. And again, this is a composite outcome, so it's difficult to understand and critique. You really got to question, is it even able to be replicated? But at the end of the day, maybe, and again, just an assumption, but maybe this at least means that the treatment with haloperidol may be safe. So seeing the adjusted relative risk of 1.2 for adverse effects, it made me want to dive through the supplemental and get a little more information. And as you can see, it's very unremarkable. The number of patients that had serious adverse events were 11 in the haloperidol group and 9 in the placebo. Other important things to me, at least, extrapyramidal symptoms experienced in 3 patients in the haloperidol group and 1 in the placebo. And then lastly would be ventricular arrhythmias, 5 in the haloperidol group and 4 in the placebo. So nothing about this was earth-shattering to me. This chart shows the use of rescue medications, open label antipsychotic use, and restraint use. So there's some neat tidbits in here worth exploring. First is the median daily dose in milligrams per day, pointing out median means the mid of the distribution. It does not mean average. The median daily dose was around 8 to 9 milligrams per day. There really wasn't much difference in folks that had haloperidol in regards to rescue medication. So it really didn't affect your use of propofol or your dexmedetomidine or your benzodiazepines if you were receiving haloperidol. In addition, it really didn't affect whether you had open label antipsychotic agents given to you either. Now, probably the most earth-shattering thing to me is the use of restraints. So these are delirious patients, with close to half of those patients being hyperactive, and there's only about an average of 2% of the population that required restraints. Now, as you're about ready to learn, this was a predominantly Danish study, and from what I'm told, both by past attendings and a little that I can find online, the Danish have a 1-to-1 nurse-to-patient ratio, so this could account for the reason why restraint use is so low, but again, I really think this is a learning point here. I think in the US, we need to identify this and make performance improvements. Here you'll see a subgroup analysis of the primary outcome. And again, there was no statistical difference in the primary outcome, but it's nice to take a look at this to try to find some signals. And there might be some trends towards improvement, especially when we look at the difference between hyperactive and hypoactive delirium. Maybe those hyperactive patients might benefit from haloperidol a bit more. The other thing I was impressed with was the mortality risk, or essentially the severity of illness. You look at the SMS ICU, and the patients that were less ill look like they could benefit from the haloperidol more. So I was very interested in this. It really made me want to have more information on coexisting conditions in the study, which really wasn't available. So now let's take a look at the strengths. So first, this was a large sample. It was randomized, it was blinded, had good, strong statistical analysis. There was very little loss to follow up, and they used validated tools in their paper, whether it was CAM-ICU or ICD-SC. They also utilized RASS not only to understand the sedation level, but also to diagnose coma, which is defined by a RASS of -4 or -5. Now let's take a look at the limitations. So I'm not sure the trial asked the correct question. I'm not a statistician or a researcher, but I would have tried to isolate the study to hyperactive patients only. We've already identified the proportion of hypoactive delirium in this paper. Still too much, I think, to answer this clinical question. I question, was the primary outcome appropriate? I would have rather seen a delirium-based metric used as the primary outcome, something similar that you saw in the secondary outcome. And again, I question, is a composite outcome appropriate in this type of trial? Another important limitation is that this is a European trial. So there's poor generalization. What that means, as Americans in the US, can we generalize this to our population? And the answer is no. Now, it might sound like I'm nitpicking here, but I really dug into the supplemental on this one. Initially, when they started this paper, there was supposed to be 18 sites enrolling participants. It kicked down to 16. Digging a little deeper, about 60% of all the participants came from only 3 sites. Those sites were in Denmark. Reviewing it even further, as far as a participant to site distribution, this was essentially a Danish study. In fact, only 36 non-Danish site patients out of 1,000 came from non-Denmark countries. So this is really a Danish trial, and this definitely shows poor generalization to try to apply it to our patient population. Next, I feel there's very limited data on coexisting conditions. I really would have liked to explore that more. We really only know if they have cancer or COVID and then some delirium risk factors. Next, there was no data on analgesic or non-pharmacological treatment for delirium, or for that fact, preventative treatment. And the enrollment consent process was kind of fishy to me. The Mind USA trial got consent right off the bat. As soon as they got in the ICU, before they were delirious, they got consent. Where in this paper, they waited until the delirium occurred to screen them and enroll them and try to get consent. And the majority of times that was done by an independent MD coming in and discerning consent. Then subsequently, once a next of kin or surrogate was found, consent needed to be attained again. And then once the patient wasn't delirious anymore, they had to get consent once more. So it almost like they ingrained some inherent difficulties in the process for obtaining consent. And lastly, enrollment was during COVID-19. It is what it is. I'm sure we'll be exploring many more papers. We'll be saying this, but I think it's particularly important because this was a sedation, this was a delirium paper. Now, I don't know much about Denmark, but I know care was different in the US as far as what our sedation protocols and practices were and what our delirium incidences were. So what was the author's conclusion? So among patients in the ICU with delirium, treatment with haloperidol did not lead to a significantly greater number of days alive or out of the hospital at 90 days in comparison to placebo. So what are my takeaways to this paper? So first, this paper does not change my practice. I don't use haloperidol for hypoactive delirium, and I won't start. When I do use haloperidol for hyperactive delirium, I'm doing it for safety reasons, and it's related to dangers to self and others. And when I do use haloperidol, I have no data telling me that it will improve patient-centered outcomes or metrics. Now, merging cumulative data over about the last 10 years, it may lead to less hyperactive or agitated patient, and it may reduce the need for other sedatives. I really think this could be argued. These are assumptions. And then lastly, it seems relatively safe when needed. So that concludes this ICU Journal Club. I appreciate you watching. If you have any questions or input, feel free to email me at rgibson2@chsbuffalo.org. Thank you.